Welcome everyone to the AbScent webinar. My name is Chrissi Kelly and I'm from AbScent. And today I have with me Dr. Jane Parker from the Department of Food and Nutritional Sciences at the University of Reading, and Simon Gane, who is a consultant at the Royal National ENT and Eastman Dental Hospitals. So welcome to you both. And
thank you very much for having us.
Thank you.
It's lovely to see you both. Great. So we are here because it's been a very momentous occasion. The paper on the molecular basis for parosmia has now been published. And I think I'd like to start out by asking Jane a little bit about the background, how you got involved in this project, Jane, and where the, what's been the storyline, if you like, for getting this paper from its inception all the way to publication.
Well, right back at the beginning, I got involved after a chance encounter with Chrissi at a flavorists conference in Amsterdam, where she was talking about her parosmia and listing this kind of foods that were tended to be triggering parosmia for people that she'd spoken to. And it was a flavor meeting, and as a flavor chemist, I kind of recognized some interesting similarities between the foods, in that I could recognize some flavor compounds in the foods that I suspected might be causing the parosmia. So, to cut a long story very short, we got together and we started recruiting people into the lab, into our olfaction lab, to look at whether this was true or not. So we had a hypothesis. We had predicted that actually there'd be some molecules in coffee that might be affecting or might be triggers for this sense of disgust and distortion that people get when they have parosmia. So we recruited, and this was pre-pandemic, so this was before COVID hit, and we recruited about 15 people and put them through our study. I don't know if you want me to go into the study right now, but I'll skip that for now. Put them through our study, and then the pandemic hit, so we got a queue of participants wanting to join. So we had another 15 people come in post-COVID, and of course we tried it out on people that didn't have parosmia as well. So we had 3 sets of people, and what we found in the end was that yes, there were particular molecules in coffee, and there were some in meat as well, and there were some in green peppers, and there were some in cucumber that were actually triggering this sense of disgust in our volunteers. And for me, that was really quite important, because we could say to them, it's not in your head, this is real. You went on the end of my instrument, and when these molecules, when you smelt these individual molecules, you got that sense of disgust. So I think that's the highlight, and for me.
And Jane, sorry, Simon, I didn't mean to interrupt.
Sorry, no, I just I've never asked you this. How close were your guesses to the for the odorant molecules or the trigger molecules? So in other words, your guesses at when you began this project about, you thought that there might be some things that caused the trouble. Were you right? Were you wrong? Were you halfway there?
I was spot on, I think, really. Pretty much. Pretty much. I mean, we've done a little bit more, and there are now some more molecules which are popping up that I perhaps wouldn't have predicted, but with hindsight can see, yes, I could have predicted those ones as well. It's based on the fact that these molecules are just highly, highly, highly potent. So I was spot on with the coffee anyway, and pretty much spot on with the meat. So, yeah.
I mean, going back to the foods that I raised in that, when I gave my talk at that conference, it was frying meat, eggs, fried food,
garlic
in general, garlic, onions, coffee. I think we pretty much kind of hit. Oh, I also mentioned cleaning products. So some cleaning products, for reasons that we perhaps don't yet understand, seem to be triggering. But yeah, I think we really pretty much covered it.
Yeah.
Does that feed? I mean, those cleaning products tend to be scented with things that, again, you don't need much of to make a very strong smell.
Yeah.
Is this the same kind of thing? That these are very potent molecules, and that's why they're the triggers.
I would think it's the same sort of thing, but I work in food, so I know a lot of these compounds are so potent that you can't see them using our standard instrumentation, and you have to smell them and know what they are. And with coffee and meat, you know, that's my job, and so I know what they are. When we move into cleaning products, it's a lot harder. I'm not familiar with them, and we haven't actually managed to work out what the compounds are in cleaning products yet. It's not as simple as it looks. You know, we've looked at lemons and strawberries and bananas, and I know as a flavour chemist what all the compounds are in lemons, strawberries and bananas, but it's none of these that is actually the trigger. So it's nothing obvious, which is quite interesting. Cleaning products is something we might move into, because I've got a new study starting up in a couple of weeks. So we might move into cleaning products and see where we can get.
Again, so it's the problem with having these very powerful compounds. You don't need many of them, and that makes them more difficult to spot on the gas chromatograph and mass spectrometry. Exactly.
Yes.
Yeah. Interesting.
Jane, while Simon's just brought up the instruments that are used in this, could you give people a little potted history of how that, not the history, but how a machine like that works, and what do you do, and what comes out, you know, what do you feed in and what comes out on the other end?
Well, the advantage of being in the lab and having technology that doesn't work is that I've got lots of props. So I've got things that I've even got a column here, so I can actually show you the kind of things that happen. So the first thing that we do is we've got this sort of needle. I don't know where it's probably best. I don't know, you can't see it, but inside there's a fiber, and we use that fiber to collect the smell from coffee. So coffee's got thousands of molecules in it that go up your nose. We can smell perhaps about 100 of them, and perhaps about 20 to 30 of them make up that smell of coffee. So we collect them using this sort of evil looking syringe, which isn't very evil. It's actually got a fiber on the end. It's a bit like blotting paper that we just sit on top of the coffee. We don't put it in the coffee, we just sit it on top of the coffee. So once we've done that, we put it into what is called a gas chromatograph. And inside that, we have a column. Now, when I say column, you probably don't imagine something that looks a bit like this, because it's actually, in the old days, it was a column. These days, it's a very fine capillary. So there's you can flow gases through that capillary. It's actually about 30 meters long, which is why it's coiled and doesn't look like a column. So what happens is your coffee molecules go in one end, and some of them travel around this column very fast. Those are the ones that are very volatile. Some of them go a bit more slowly, because there's some special material on the inside of this capillary, can you believe, which is actually, some of them are attracted to. So that's how we get the separation. And then what comes out the other end is molecules, one at a time. And what we can do is, at the other end, we attach a little nose piece, and we have the volunteers sniffing. And these molecules come out one at a time. So we can actually gauge people's reaction to these molecules as they come out. And right from day one, it was really obvious which ones were causing a problem, because there were some that were, when I say normal, there was a normal reaction. They were perhaps green or perhaps fruity. But when the ones that were particularly nasty came out, people's reaction was instant. It was like, whoa, that's parosmia and that stinks. They could rarely describe the smell. They had to use words like, it's a bit like sewage, a bit like smoke, a bit like chemical, a bit sickly, but they couldn't describe it very well. But they did know that that was something that they associated with parosmia. So the very first participant was just so exciting, because it showed us exactly what we had thought right back at the beginning. So I just
So
tidy up my columns.
The sneaky bit is the little Y split just before the sniffing port, obviously, because it goes off to the other part of the clever bit of the machine, which is the mass spectrometer.
Yeah, so that's how we identify. So you smell half of what comes out, and we analyze the other half. So we've got a mass spectrometer which will essentially identify these molecules for us if it's sensitive enough. Now, this is the interesting thing, that the human nose is far more sensitive than even the most sophisticated, expensive mass spectrometer on the market. So that's why we use human noses. And that's a lot about what my job is. But yeah, so sometimes we see them, but an awful lot of these compounds we don't see because they're so potent and they're present at such tiny levels that actually we don't see them on the instrumentation. So that's where I come along, and I have to smell the same run and see if I get smells at the same places that the people with parosmia do.
And can you then go, oh, that smells like this from the captain or whatever? You recognize the smells of the molecules and go, okay, that's what we should be looking for. And that's what I expect to come off the column at about this time, at this temperature.
Yeah, so we've got a few criteria. So does it smell like what we think it is? Is it in the right place? And is it in coffee? Does it make sense? So we tick those 3 boxes. And then we have to have a leap of faith, really, in that we have to assume that what I'm smelling is what the other person is smelling, which for parosmia is not necessarily true. So what we have to do is perhaps go and find a bottle of that molecule and give it to the person with parosmia and see if they react in the same way to that. So that's a cross check there.
I think that's the first time that we've ever actually seen gadgetry on one of these webinars. So I'm really glad that you've brought those things along and you can share them with people who are watching. That's great. So Simon, let's ask you a couple of questions now. Why don't you tell us what you see in your practice with people who have parosmia, and from the clinician standpoint, why is this such a pressing issue?
Yeah, well, I mean, it's pressing for maybe obvious reasons for the past 2 years, but to go back, when I see people in my smell clinic who have problems with their sense of smell, I like to think of it as two sort of slightly different directions where the smell can go. The one is just that they can smell, and they have the ability to smell, which means they can detect molecules that are at a certain strength, like they can smell weaker or stronger, and sort of everybody's ability to smell varies on that axis, from what we call normosmia, it's a normal functional sense of smell, to a weaker sense of smell. You're not as good at picking up odors, you're not as good as identifying odors, you're not as good at distinguishing one odor from another, to and we call that hyposmia, to at the very end on the other side, you can't have you don't have a sense of smell at all. You know people walking around with a clothes peg on their nose can't smell. So, and that's anosmia. But all the way through that, the smells are normal and expected and smell like what you think they should smell. And then kind of at 90 degrees to that, so people can have smell dysfunction in which the things that they smell change. So we talk about, and a paper that we've all published together talked about 3 of these smell dysfunctions that are related to, but not exactly tracking that baseline ability to smell. And they are parosmia, phantosmia, and olfactory perseveration or smell lock. And the problem with these is that things don't, you can smell something that you expect to be normal. You talked about roasting meat, or a garlic frying in a pan, or coffee, or toothpaste. These are sort of the commonest triggers that Jane's paper found. But they smell disgusting. They don't smell like they should. But there's an additional on top of this sensation of disgust. So this disgust is a primary emotion for humans. It's an emotion that is supposed to keep us safe. We learn to avoid things that disgust us, and so there are some of these things that are programmed in. So the smell of rotting meat, very bad for humans to consume, and we are naturally avoidant for that smell. Whereas the bathroom smells, as we call them, dirty nappies and things, actually seem to be learned disgusting smells that babies and young infants doesn't really bother them in the same way as the rotting odors do. But all of these smells get sort of transposed onto things that should smell nice and normal, and that disgust makes people go, I don't want to eat that. That's bad for me. And that emotion gets sort of stapled on to these altered smells in some way that we still not quite sure why. And it can become a real problem. I've had people who, their diets shrink down to one of three things because they just cannot physically, and it is physical. That's as Jane said, the nice thing about this paper, physically face eating these things because every fiber of their being is going, no, don't eat that. That's disgusting. It will kill you. So phantosmia is slightly similar to that, except it's more of a background spell. I talk about parosmia as being triggered, altered, and unpleasant and disgusting. Phantosmia doesn't seem to have the same triggering, tends to be sort of a background awareness of a chemical burnt smell. Also can be quite problematic, but isn't as closely associated with a particular foodstuff. And then finally, olfactory perseveration kind of mixes the two together in that, and we were talking about cleaning products earlier, and most people experience it with cleaning products, so the smell gets stuck in their nose. And so it's triggered by something, they can smell something for the first time, and then it stays in their nose all day, and again, has the same characteristics of phantosmia. And those are the three olfactory dysfunctions. And what we showed in the paper is that this correlates to a certain extent with your ability to smell, but it's not absolute. You could have an otherwise measurably normal sense of smell and still have debilitating parosmia, because the things that you can still detect them, but they're disgusting to you, or you can have a very poor sense of smell and have parosmia, and vice versa. So I think it's very important, especially since a lot of people are now dealing with these symptoms, to really to push forward on our research here and try and isolate what's going on and understand. And that's why this paper, I think, is such a landmark paper. Although the reviewers made us take out the word landmark, I think.
They did.
Or something like that, yeah.
They did.
Because we were, they weren't as excited as we were.
Yes.
But I think it is a landmark.
I think it's it's important to bring up the fact that there is a mental health burden that's going with parosmia that really we need to start taking into account. As you said, Simon, every fiber of your being is saying, don't eat this, it's dangerous. And you're having to override what is human instinct.
And that's exhausting. What you used to do for pleasure, now is a chore.
Yep.
You know about this from your point of view, Chrissi. Yep. You've been through it.
Yep. Yep.
Can you tell us what it's like from your side?
Well, you just have to keep steeling yourself and putting the food in your mouth. I am one of those people who initially, once I developed parosmia, I lost a lot of weight because I just couldn't face eating. And then as I started to recover, the weight went on. So there was a bit of weight fluctuation because, of course, in the very beginning, when I didn't have the parosmia, I was trying to chase the experience of satisfaction by overeating. So that was a period of weight instability, and I think a lot of people are also experiencing that. But maybe we could talk a little bit now about where you see where's the damage occurring, how is it happening, what is the mechanism, because we seem to be there is a hypothesis that says there is aberrant regeneration of the olfactory neurons on one side, and then on the other, we know that, for instance, that people who have parosmia, if we rig them up and we look at what's happening in their brains when they smell these things, that certain parts of the brain are activated that are associated with disgust. So we don't really know what's going on the inside, but Simon, could we have your view on that?
Yeah, I do. I have sometimes it's easier to use pictures to do this, but I don't think I'm allowed to share my screen. So I'll try to busk it from here. Oh, really?
I think I can.
Let's just see if I can find.
Okay, Simon, you're now the host.
Oh, I'm the host now. Right. So let's just share this picture if I can. There we go. So smell is the way that the body detects molecules, and the way that happens is that the molecule comes in. Can you see that?
Mm-hmm.
Yeah, activates a specialized protein that's on the cell membrane of the nerves that are hanging into the nose, the olfactory nerves. Activates a G protein, which is a special sort of receptor that activates it, causes a sort of a molecular cascade inside the nose, switches on that whole thing, and then that activates the nerve and sends a signal up to a specialized structure within the olfactory bulb, the bit of the brain that's just above the nose, called a glomerulus, and that switches it on. And so you can see here, I like to sort of liken this to one of those old-fashioned switchboards, where you've got a bank of lights with different wires connecting up to them. And what we perceive as a smell is the sort of differential activation or the pattern of activation of those lights. So, for instance, you have an M molecule that switches on the M receptor, and that goes to the M glomerulus in the bulb. But you can also have an E molecule that switches on the E receptor and goes on to switch on the E glomerulus within the bulb, and an R, LOT, and that pattern there gives you the smell of Merlot. But it's equally possible that you switch on just the O and T, so you have molecules that switch on O's, molecules that switch on T, but instead of the MERL, you switch on the I and the P, and you get the smell of Pinot. So there's some similarities. There's molecules that are the same between the two, and they're both wine, so you can detect that. But the differences are the difference in the smell characteristics. And so what's happening with that is that you've learned, your brain over time learns these patterns. You can imagine it looking at this pattern of activation of the bulb and going, okay, now that, oh, those have lit up, that's Pinot, that's Merlot. But what happens, well, what we think happens is in any of these insults that damage the smell system, those nerves get wiped out. They get, partially or completely just obliterated. And the good news is that in everybody, the nerves are regrowing all the time. There are specialized stem cells in the nose that are making more of these nerves, and they're growing, and they can grow back into the bulb. This is what's going on all the time. So instead of, let's do this again. So you can, and just to say, within the bulb, there's a very complex network of interactions. So some things switch on something, other things, and some things switch them off, etc., etc. And that network remains even though the inputs die off. So you're getting, sorry, that's the wrong one. These things go into the brain anyway, and that's what you recognize as the Pinot. So we were getting regeneration all the time. So a nerve will die off and then it will regrow from the stem cells, and it knows to regrow to that same part of the brain. It knows if I've got an I receptor on me, I'm going to grow to the I glomerulus. But then probably what happens, good, I need to stop sharing that now. So probably what happens, well, what we think happens is that if you wipe out enough of these nerves, they start to regenerate, but they don't have the cues to tell them where to go, and they start to go to the other glomeruli. And it may not be one, it may not be all, it might be just a mixture of the two. And they then, because they're innervating lots of different glomeruli, one, say that I receptor now switches on 3 or 4 different bulbs kind of weakly, which then interact by a complex network to switch on others or suppress others and things like that. And you get this mishmash of signals that your brain is looking at the switchboard, which is flickering, and some things are going off and on, and some things are not, and that becomes extremely unpleasant for the brain, and it says, this is disgusting, this is a bad idea, whatever it is, it's doing something horrible to us, let's avoid it. And that's kind of what I think of as the prevailing paradigm. But in our very many talks over these things, we're not sure about this, and Jane and I've come up with some other theories that might also explain this. Jane has the orchestra metaphor for this, the lone trumpeter, we call it.
Jane,
I do.
Explain that.
That sounds like a cue, doesn't it? So, yes, I use the orchestra as an illustration. And if we're talking about, yes, the hypothesis is that you're losing members of the orchestra, okay? And if you've lost, all the violins, all the strings, you've got a partial orchestra there. And the music's going to be a little bit distorted. You may or may not recognize what it is, what the piece is playing. You might recognize bits on the bass line, but really the whole experience of the music is distorted. And that's how I define distortion. And that is sort of represents the fact that you've lost a lot of your olfactory sensory neurons and they're growing back. So in my mind, the orchestra is, very slowly they're coming back to their seats and you start to get a better impression of the music that's playing. But what happens with parosmia is that there is this real sense of disgust. So it's not just that there are people missing from the orchestra. The people missing from the orchestra is what they call the incomplete odour characterization theory. And that was postulated centuries ago, actually. But more recently, 2002, I think it was, somebody actually wrote in a paper that this is incomplete odour characterization. And this is why you get this sense of disgust, because you haven't got that balanced orchestra anymore. You've just got the piccolo standing out and that horn or whatever. But the sense of disgust is harder to explain. And for me, that's, Simon said the lone trumpeter, but I've got a foghorn in the back row of that orchestra. And that's
somebody
a
in the
foghorn.
chat just said vuvuzela.
Yeah, exactly. The same thing.
Yeah.
There's a foghorn in the back row and you cannot get that out of your head. And that is causing you pain and distortion and disgust. And no matter how much of the orchestra comes back, how much your olfactory function recovers, if you've still got that foghorn there, it's still giving you that sense of distortion. And that's what I see as parosmia. And what you have to do is just try and recede that foghorn. And I think over time, that's what's happening. At the same time, the orchestra are coming back. So it's a balance of these two things. Your olfactory function is improving, so you're getting a more balanced signal anyway. And the foghorn is off in the distance, but it takes time.
I think
and we've seen that with that new paper from Alton in Turkey, showing that smell training actually helps with parosmia. I mean, it's just recently published. And we've, again, suspected this for a long time, but I think that's the first evidence that it really does help with it. And it makes sense in terms of this. The orchestra members are coming back in and they're kind of, because you get this network of interactions that has been destroyed by the initial insult, but are still there to a certain extent within the nose. I think the increased inputs then start to tell the vuvuzela flat player to sit down a bit. Don't listen to that one as much, and sort of reintegrate the symphony of smell.
Certainly, that's the question that people ask probably the most frequently in the parosmia forums is smell training, is it even worth bothering with smell training? But I would say that, obviously it is, but as you pointed out, Jane, the fact that you've got parosmia says that you actually have a sense of smell that is functional. And parosmia is always lumped together with the smell dysfunctions as if it's a sort of diminishment of your olfactory experience, when it can actually be so powerful that you might have to leave the room if
Yeah.
you were, you know, somebody was brewing coffee, as an example.
Yeah, 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 and that can be a real problem for some people. And also, don't forget, and this is what I tell my patients all the time, they're not always that happy to hear it, is that parosmia is considered a positive symptom. It predicts, I mean, that there sort of, it's been shown that there are four things that really predict recovery from smell loss. It's that if it's post-viral, if the person is younger, female, and if they have parosmia. And all of those things really predict that your smell will be, you know, will recover to a greater degree. And that's because it's a working system that's just been thrown out of whack a little bit. And if we can convince it to come back in whack, then we can then it's a very good chance that, you know, you get a functional, enjoyable sense of smell back.
Mm. Simon, what can you tell us? Is there anything else that you'd like to give us a little background on that Alton dog paper? I think they looked at it was modified smell training as well as traditional. Is that right? Yeah,
that's right. I think they called it extended, did they, or modified? I can't remember. But again, it I always have in the back of my head, I feel slightly guilty because it plays to all of my biases. I believe this from talking to you, from talking to my many other patients. The more attention you pay to your sense of smell in terms of smell training, not only with the Hummel 4, but with as much as you can, the more you do it, the more things you do it with, I think the chance of recovery is greater. And I'm not sure whether that's the people who pay more attention are the ones whose smell is more important too, and therefore, you know, they report their recovery more accurately. I mean, ATOG definitely measured outcomes, but it confirms all of my biases, and therefore, as a scientist, you always have to have just a slight pause before going towards that, because you know, one of the easiest ways of sneaking in pseudoscience is to play to biases. But I do believe that it's true. It's, you know, it agrees with everything else that certainly I've seen clinically. You're putting more, not only I think you're recruiting more nerve cells within the nose, you're also using the brain's own ability to change and learn, what's called neuroplasticity, to devote more processing power to it, to the sense of smell, and that we know is very important too. And
you know, I think we hear a lot about how the brain can heal itself. We've just heard that the olfactory system has the ability to regenerate, and then we've also heard about brain plasticity. But those are two actually very different things. I mean, the nerves are regenerating in the periphery, that is to say, outside the brain, and brain plasticity is obviously happening in the brain. But there seems to be very compelling evidence that smell training really does change the structure of the brain and the thickness of the tissue and so on. Joe Frasnelli's paper on what happened with sommeliers who were training, that showed a marked change in a positive way for the brain tissue.
Yeah, all of these things are natural processes that we're using to I mean, it's kind of the definition of rehabilitation, right? It's using what the body's already capable of doing and doing anyway, just making sure it does it in the most effective and efficient manner. And yeah, like you said, we know from sommeliers, from parfumiers, that you know, we know that when you start as a parfumier, your sense of smell is no better than baseline normal. But after 3 years, you're an olfactory genius, because you're just doing this all the time and paying attention to it.
Right. And of course, it has to be said with all of these things, we're talking about people who self-report parosmia, people who self-report that things are getting better. And we have to say, you know, that there really are not, we are restricted in the way we can test people. There's the objective the standard test for testing sense of smell is the Sniffing sticks test, which Jane gives in her lab. But as far as an objective test for parosmia, and an objective test, of course, is one that is administered to you by someone else that perhaps gives a score that can be compared to other people, that there really isn't a good objective test for parosmia.
Well, almost for anything in olfaction, right? I mean, ideally what you want is an objective test is you're looking for what we call a biomarker, where the person who's having the test doesn't have any way of influencing its outcome. That's a truly objective test. If I do a full blood count on somebody, the number of cells that I'm counting in that full blood count, it doesn't matter whether you are unconscious or running a marathon or sitting quietly in a room. The number of cells you're not going to be able to change those things. And that we have some things for smell, but they're very tricky and fiddly to set up. So almost everything else we have is a semi-subjective test, and that we're relying on people telling us the answer, including the sniffing sticks. And the same, is really true for parosmia. We don't have anything that you can, point a camera at someone and say that person has parosmia and that person doesn't, even if they are unable to tell me it. And that is in some way a holy grail for us to find that thing to measure.
And Jane, as somebody that works in a sort of lab that you work in, you obviously have a great deal of expertise in using the equipment that you've just described to us. You will have a very high level of ability in parsing out smells, understanding smells, and so on. How blunt of a tool do you think the Sniffing sticks test is if you are looking at people that have, let's say, a very, a high level of experience with talking about getting the vocabulary and being able to, let's say, pull apart a smell that you smell. You might be able to smell 2 or 3 things in an individual smell. So do you have any comment on that?
So the Sniffing sticks test is designed to measure olfactory function. And so it has 3 parts, and it tests your ability to identify things. And it tests your ability to pick the odd one out when you're presented with 3. So what's the odd one out? And the third one is threshold. And that's where the Sniffing sticks test could be better, because in that case, you're only looking at one molecule. You're looking to see at what point your patient starts to notice that molecule. And if that person happens to be a bit insensitive to that molecule, but perfectly good at picking up everything else, then their score will be quite low. So it does rely on just one molecule. But of course, it also is not designed to measure parosmia. And there are some sniffing sticks in there that are frequently picked up as parosmic. And I noted that it was anecdotal for me. I just noted down the ones that people were mentioning. You could formalize that a little bit, because one set of sticks are single molecules. And so we know from that there are some other single molecules which are causing distortions. But the identification is those sticks comprise, 10s, 20s, 30s of molecules. I've tried to analyze them, and they are complex flavorings. So they will have numerous compounds in them. And there are some in there that cause that sense of distortion, the coffee one in particular, and there's an onion one. But in that set, there's not much else that tends to cause distortions. So that test is, I'm not quite sure what your question was, but that test has got its limitations for olfactory function, but it's the best we've got, and it works, and it's a pretty good measure of olfactory function. It's not a measure of parosmia, and that's where we need to devise something. The problems with devising something is the fact that people are sensitive to all sorts of different smells. So if you designed one for coffee, that might work for the people that find coffee a problem. It may not work for the people that find cucumber a problem. And it may not work for the people that find shower gel a problem. So you've got to find what the molecule, the whole set of molecules in all these things, and actually combine them into one test would be the ideal way to go.
So what do you think are the, what's the next frontier? Where are we going next with this research? What do you think, where do you see the greatest need? What would we like to know? How can we corroborate what we found out so far? Simon?
I was just thinking about that. I mean, I think that what occupies my mind the most now is trying to work out who has the vuvuzela and why they're playing it. What's the are we right? Is it this mishmash of inputs into a system that's balanced to have a different set of inputs? The reason that we find it disgusting. Why is an odd activation of the olfactory bulb so viscerally revolting to people? In that, but other people will go, oh yeah, it's altered, but it's not disgusting, which I think is a smell alteration, but not a true parosmia. And so I think narrowing down our definitions is important. Really starting to drill down into exactly what we mean when we use these words. There are a number of words with very long histories that have been sort of thrown around in different ways, and I think coming to a consensus agreement on those would help, because you can't compare studies on parosmia if you're not using the same definition. And then, as Jane said, working towards some kind of better test for it, and agreeing, seeing if we can find something that really. So I'm not worried that things smell bad. I'm worried that people who have parosmia have horrible lives. They have, unenjoyable food and limited diets and all those things. So something, for me, I want to see something that looks at quality of life impact, in addition to, say, number of triggers, severity of triggers, those kind of things, and maybe some kind of tool that allows us to encapsulate that quite nicely in terms of outcomes. And then, as I said, mechanisms. I think because once you understand a mechanism, you can start to tinker and start to look at treatments. Not that actually not knowing the mechanism stops you from getting treatments. So that might be something we can talk about as well. Jane, anything to add?
Yes, I think in terms of my orchestra, it's working out why the flute suddenly morphs into a foghorn.
Yeah.
Because that's what's happening, because these molecules are perfectly normal for everybody else. So why does that flute suddenly become a foghorn, which is exactly what you were saying? And for me, it's the understanding there are two parts. There's what's happening in the nose and there's what's happening in the brain. And that conversion of flute to foghorn is something that's happening, I believe, in the brain. We've identified the fact that the flute is a foghorn. But I mean, I don't know if that's true, Simon, you're the expert in this, but why does the flute become the become the foghorn?
Yeah. No, exactly. You're exactly right. The flute is perceived as a foghorn, but that's fine. Okay, it's a loud noise that's unpleasant. But why does it suddenly pick up this baggage of disgust? Is that a natural response to novel odors? No, I mean, we smell new things all the time, and that's not. So it's something about the distortion and the imbalance. And we know there are other things that are wrong in the smell system in recovering noses. Chrissi was the first to describe olfactory flashes. There's something around this term called habituation, where we become smell blind to things that we're exposed to over a long period of time. I'm sitting in a very small room. If I had a scented candle in the corner, I would smell it for the first couple of minutes, and then I wouldn't smell it anymore. But if somebody came in, they'd go, oh, that jasmine candle is really powerful. And that habituation seems to be all out of whack in the recovering nose. So people habituate like that, they get a smell and then they can't smell it again, or vice versa. You can think of parosmia and olfactory perseveration as the failure of habituation. So I think it's looking at all of those processes, and we kind of understand some of those steps of habituation. It happens at multiple levels in the olfactory system. So something along there, I think, is the foghorn, or is responsible for the foghorn. But again, why does that mean that it's disgusting? And why isn't it disgusting to everybody then? Why is it, you know, of the fraction of people who have permanent smell loss from COVID, or long-standing smell loss from COVID is maybe a better way of putting it, why do only a small amount of them then go on to develop parosmia? And why are only a small amount of them really quite fortunately quite debilitating parosmia? So all of those are questions that still have to be answered.
And I think the thing we haven't touched on is what we've termed fluctuations.
Yeah.
Because that's when, before parosmia hits permanently and forcefully, people are reporting that they can smell normally, or, you know, for perhaps a day or so.
Yep.
And the olfactory function is coming and going. And there's flashes of parosmia and flashes of normality. And there's some very preliminary research, which I think is still, you know, at very early stages, suggesting that actually pre-COVID, okay, maybe your olfactory neurons are destroyed and they have to grow back, but post-COVID, there are people who think that perhaps the olfactory neurons are not totally destroyed and they're still there, and it's some other function, perhaps an immunological function, which is switching them on and off. So there's that possibility as well. And I think that's quite fascinating, because that idea fits with what we're seeing in fluctuations. Otherwise, we can't explain fluctuations at all if we're looking at just destroying olfactory neurons. So,
I mean, as usual, I can come up with a story to explain it, but it's only a story, even with the destruction.
Well,
but yes, I agree.
Then.
I think that. Well, again, if you have a network with attractors in it, so you build the olfactory bulb with sort of feedback loops and various sort of suppression and activation relationships between the nodes in that network, you can imagine that you can set up feedback loops and oscillators within that might work better and sometimes than in others, depending on the other inputs and the stage, etc., etc. Again, that's just a story. It's without any research, it's not particularly helpful one. But I agree. I think you know, it was quite amazing when we found out that the SARS virus needs ACE2 receptors and an enzyme called TMP-RSS to get into cells, and olfactory nerves don't have those receptors on them. It doesn't invade olfactory cells, and yet we have this, you know, plague of smell loss, and it looks to be the sustentacular cells that are the problem. That feeds right into your theory that those nerves may be suppressed in some way, and if so, that's really exciting, because if they're there, we can probably bring them back. The only problem is, to see if they're there, you have to go and look in with a biopsy, and I'm not sure. Chrissi and I have talked about this before. I'm not sure people who already have a poor sense of smell are really willing to risk losing it all just to have a look and see whether they've got nerves or not. There are probably ways around that.
And of course, you know, going back to your comment about bias and, you know, people who report really extreme parosmia, you know, we don't know that perhaps those people were people who had a very sensitive smell before they lost it, and that the parosmia that they're experiencing is some kind of heightened sensitivity that they're returning to. So again, those are things that we just don't know, you know.
I think you're exactly right. And sorry, Jane.
No, go on.
I was just going to say, from my clinical experience, I think that the people who are the most devastated by their smell changes, whether it's loss or distortion, are the ones who say, you know, I was always the best smeller in my family. I could, you know, smell a rose at 50 paces. It's very common for people to report that. Not everybody, but it's very common that they are experience a much greater delta in their smell ability, even though sometimes I'll test them, they're pretty much normal on the smell tests that we've been talking about, but there's such an awareness of the loss, and that's what's so distressing for them. because they were such good smellers to start with.
And I was going to say exactly the same thing about the people that came into Reading to do the study. So many of them were reporting that they were the person that could sniff out whatever. Yeah.
Yeah. Yeah, absolutely. And maybe that, I mean, that might be quite interesting to see. I'm not sure how you'd do that.
It is, but the people that are less interested in smell and less affected by it are far less likely to seek help. So
yeah, they don't want to go all the way to Reading. Yeah.
So Jane, what's the next thing that's going to be happening in the lab at Reading? What are your plans?
Well, I'm not sure I want to divulge all my plans,
Okay.
but
secret plans, those are the best kind of plans.
we are starting to have people come back in. One thing we're very interested in is people who have an aversion to water. We've got a test we'd like to do with people that we want to find out what's in water that's causing a trigger, because that's one we don't know yet. We're still hunting down triggers in things like strawberries, bananas, apples, because that's not obvious. It was obvious to me in the coffee and the meat and the peppers and the cucumbers, but the strawberries, bananas is a difficult one, and there tends to be a greater variation between people in those ones. So we'd like to try out strawberries, bananas, and Coca-Cola or cola on some people. The habituation is very interesting because we see the habituation in both directions, because you see the people that just don't habituate, possibly, or perhaps that's the reason, but we see people that when we give them two sticks that are identical, they smell the first one and don't smell the second. So that all contributes to the sort of habituation distortions, whatever, as you were describing earlier. So we've got I think that's a couple of the studies, and we'd like to look at a objective test for parosmia, but I think there are other groups doing that as well. And we don't need it, you know. I suppose if you're going to look at something long term, which is would be a really interesting study, would be to look at people with parosmia long term. Then you need the objective test, but that's quite a big study, and that's something that needs funding, which we don't have at the moment.
We never have. Yeah, I mean, I would go back to your objective test for parosmia. I think it's actually a really difficult thing to do, because if a person is only reacts to one thing very, very strongly, and it means that their life is ruined by it, is that the same as somebody who reacts to a number of things quite weakly and gets on with their life and manages to drink their coffee in the morning because they need caffeine? Chrissi Kelly.
So
how do you compare those two? I'm not sure you can.
No, and that's
we
why
know which person's life is worse.
And that's why the test we were going to propose was a combination of how do you react to these sniffing sticks, how do you react to these common foods, and how has this impacted your quality of life, your appetite, your diet, so that was what we had proposed to do. And I think that's the only way to try and get at it. But if you came up with anything, you want to validate it against something, and you've got nothing to validate it against, because other than people saying, yeah, my parosmia is this bad. So it becomes a bit of a vicious circle.
Yeah, it's always the problem with medical tests. Always.
Yes. Yeah.
We are quickly running out of time. I saw one question I thought I would like to answer, or at least bring up. Mo has asked about whether or not the vaccine is responsible for parosmia. And this came up a lot, obviously, when the vaccine was introduced. We don't have to go into a full explanation here, but I think that Simon, I'll turn it over to you, but I'll first say that, of course, we had probably close to a year of people coming into our forums and talking about how parosmia was arriving 3 months after the initial insult. So Simon, do you have anything else to add to or I'm sure you have much more to add to that discussion, but I'd love to hear from you.
Well, I mean, you're exactly right, and this is the. I mean, I talked about the problem with medical tests. The problem with knowing anything in medicine is there's always a background rate of occurrence of these things. So, if, as you say, if people are getting parosmia a variable amount of time after their initial insult, and they report that their smell is back to normal in that meantime, you could blame any one of a number of things that happens in those 6 weeks to 3 months for the parosmia. But unless you do the study where you take a group of people and you say, right, for the next 3 months, we're going to just watch everything you're going to do, and the others you say, right, in 3 months' time, you'll have the vaccine, and you can see a very strong shift in the rates of parosmia in those two groups, you can't say. What you can say is that if your chance of dying from getting COVID, if you don't get the vaccine, is very significantly higher than anything else, then the impact of parosmia is going to be less than dying. So even if it did cause a slight uptick in parosmia, and I mean, I very strongly doubt that it does, but let's say it does. The bad, as we've said, the people who really get bad parosmia, where it's really affecting their life significantly, they're very, very rare in terms of the overall infection rate. I mean, if it happens to you, it happens 100% of the time, as the saying goes. You know, it can be devastating if it happens to you. But if you are coming to the decision of whether or not to have the vaccine, the rate of parosmia occurrence is not your worry. The rate of being in intensive care is your worry, and that's, you know, many orders of magnitude higher. So just on, and not only the chance, but also the degree of impact on your life is even higher than that. So in terms of just rationally choosing one versus the other, the numbers say have the vaccine. And you know, and I think that's the calculus that most people can perform when they do that, right, if they have the right information available to them, which is unfortunately not always going to happen.
Good. So thank you, Simon, and thank you, Mo, for that question. Before we wrap up, Jane, are you recruiting people at the University of Reading, or are you not at that point yet? Should we be?
I haven't started, but I will be starting in the next week or so. So yes, if you're close to Reading, if you're finding coffee a problem, particularly because we're still looking at coffee, if you're finding water a problem, and strawberries, bananas, apples, whatever, we're interested to hear from you. Pretty much, if you've got some foods that you find disgusting, we'll put them through our machine and try and work out what it is that is causing the disgust. So yeah, if you're close to Reading, there is an email address which is olfaction@reading.ac.uk if you want to register your interest. We will be doing that. We've got a student here for the summer who will be helping run that, so that's going to happen.
And
for those of you who are not English, it's spelled reading, as in
yes,
to read a book.
And as always, for anyone who is interested in getting involved in research or learning more about the research that's going on in this area, and you'd like to participate, do come to abscent.org, where you will find a link to our network, and it's in the network where we have a special channel for research, and we can help you out with that. So I'd like to say thank you very much to Dr. Jane Parker and a consultant ENT Simon Gane. So thank you very much for your contributions today. Thank you to our audience, and we'll see you at the next webinar. Goodbye.
Thank you for having us.
Thanks, Chrissi. Bye.
Bye-bye.
Thank you for having us.